States have high blood pressure, and that translates to about 75 million people. They also estimate about 8% of adult Americans have undiagnosed high blood pressure, and it's a very significant problem. It's a leading cause of heart disease, coronary artery disease, congestive heart failure, left ventricular hypertrophy, which is a significant heart problem. It also causes chronic kidney disease, eye problems, and it can reduce the quality of your life and shorten your lifespan. And unfortunately, only about 50% of people with high blood pressure have their blood pressure adequately controlled. And there's a lot of reasons for this. One of the reasons is people don't have access to care, although hopefully with the Affordable Care Act, more people are coming in to the doctor, and it seems like more employers are requiring a wellness screening, which we find a lot of people with high blood pressure through that. So lack of access to care is not as big of a problem as it used to be. One of the big problems with high blood pressure is that people don't have any symptoms, and so it's really hard to sell treatment of a disease where you don't really feel anything is wrong with you. So that's a significant problem. And if you do have symptoms, I'll go into that a little bit later. The symptoms are very subtle, and it seems like a lot of my patients, or patients in general, are worried about side effects of potential medicines we give them. And you know, if you have side effects, we adjust the medication, and that's not too big of an issue. I'd also like to interject something at this point. If you guys have any questions about something I said, or something on the slide or something, feel free to raise your hand. I'll try to answer as many questions as I can.
When you say controls, what's your definition of controls?
Good question, because I think we're getting into that on the next slide. Okay. Here we go. Normal blood pressure is 120 over 80 or lower. If your blood pressure is between 120, the large number is the systolic number, or the upper number. So if you're between 120 and 140 and 80 to 90, we used to call that pre-hypertension. And that's a little bit controversial right now amongst experts. And I think generally in 2015, if you're below 140 over below 140 over 90, then that's considered normal blood pressure. If your blood pressure is between is over 140 over 90 to 100 over 60, that's called stage 1 hypertension, and that's mild hypertension. If it's over 160 over 100, that's called stage 2 hypertension, and that's moderate. We used to have a stage 3, but the experts have eliminated that from their terminology. And stage 3 was considered over 180 over 110, which is pretty significant.
Sure. If you take your medicine and it works, and your pressure is below 120 in the beginning, I read you're not supposed to take it. I've had it like 111 if it really works.
Yeah, that is on the low side, and that's something that you should discuss with your physician, because
otherwise it goes up. It's like the stage 1.
Right. Well, what we'll do in those cases, if you're on medication, is try to reduce your medication. And some people, real low doses of certain medications work really well. So when you start getting below 120/80 and you're on medication, you run the risk of where you get dizzy and lightheaded, you could fall down and break a hip or something like that. So yeah, that's something to talk to your physician about if it's getting too low. And I usually, when people are getting down to 110/70, I usually reduce their medication. Yeah, you might have something called labile hypertension where your blood pressure goes up and down, and that's kind of a difficult problem to treat. Okay. I wanted to talk to you guys about the risk factors for high blood pressure, and one of the most common things is as we age, our blood pressure goes up, and it seems like around 60-ish is an age where we see high blood pressure more commonly, although with that said, I do have patients that are in their 20s that have high blood pressure, and 30s, and so on. And so age is a risk factor for high blood pressure. And the second problem up there is obesity, or being overweight, and that is a major problem now in the United States, as we all know. Obesity raises your blood pressure, and it tends to cause diabetes and also sleep apnea. And all of those problems can contribute to high blood pressure. So losing weight is a really good treatment for your high blood pressure. Another risk factor for high blood pressure is lack of physical activity. And I think we all, have cars and tend to drive everywhere, and just light activity, which I'll get to a little bit later, can lower your blood pressure significantly. So, if you look at most of America, most people don't get enough exercise. And when I say exercise, you don't have to ride your bike around the lake or run a marathon. Just 30 minutes a day of even walking will lower your blood pressure. Other risk factors are family history, and I find I have some really fit 20, 30, and 40-year-olds that are super healthy looking, super thin, super athletic, eat perfectly, and they have high blood pressure. And when you ask them, usually they have a parent or a sibling, or a parent and sibling with high blood pressure. So sometimes if you have family history of high blood pressure, the genetic factors are really powerful, and lifestyle modification may not reduce your blood pressure. You may need to take medication if you have a strong family history for high blood pressure. African Americans tend to get high blood pressure at a younger age and get it worse than the rest of our population, and we usually treat African Americans a little bit differently with different medications. They respond to certain medications differently than the rest of our population. High sodium diets are really prevalent here in the United States, and that's common in any prepared foods. I tell my patients anything in a bag or a box is probably got a lot of sodium in it. And canned soups, a small can of Campbell's soup is about 900 milligrams of sodium, which is a huge amount of sodium. So some patients, if you just eliminate all salt from their diets, then their blood pressure will come down. So that's a real significant thing. Excessive alcohol intake also leads to high blood pressure. In men, if you have more than 2 drinks a day, that could raise your blood pressure. In women, actually only 1 drink a day can raise your blood pressure. So that's an important risk factor too. And excessive alcohol intake is also a risk factor for coronary artery disease. And coronary artery disease is when the arteries that lead to your heart muscle get clogged up with cholesterol, or the muscle in the artery gets too tight from high blood pressure. That leads to coronary artery disease. And alcohol intake is a risk factor for that as well. Low levels of vitamin D may contribute to high blood pressure, but those studies are ongoing. Also, it's not up here, but certain personality traits, like people that are really impatient or angry a lot, or some people with depression can have high blood pressure. patient not too long ago that every time I'd see her, she seemed very angry, and I asked her, "Are you angry? Is everything okay?" "No, I'm okay. I just don't want to be here." Her blood pressure's really high and it's poorly controlled. And I finally, we gave her enough medicine, her blood pressure came down, and then she began to argue with me about why she was taking so much medicine. I said, "Well, look, your blood pressure is okay now. You should take your medicine. You're feeling okay. There's no reason not to." And she just continued to argue. Finally, I said, "You're raising my blood pressure. I think you're going to find a new doctor." But I think, we all encounter people like that, but that's hard to change for people. That is a risk factor as well. There's also what we call secondary causes of high blood pressure, and there's certain tumors of your adrenal gland that can give you high blood pressure. Kidney disease, it's kind of like the chicken and the egg. Like when you have high blood pressure not treated, you get worsening of kidney disease, which worsens your blood pressure. So chronic kidney disease is a factor in high blood pressure. Endocrine problems can cause high blood pressure. There's certain endocrine tumors that can raise your blood pressure. So if my patients aren't getting improvement in their blood pressure despite treatment, then we start to look for secondary causes of high blood pressure. And if we find a secondary cause and we can correct it, then your blood pressure will come down. There are medications that we commonly prescribe that can cause high blood pressure. Birth control pills can do it. Sometimes you'll see a young woman with high blood pressure and they're on the pill, and then we stop the pill and their blood pressure goes down. NSAIDs. I don't know if you guys know what NSAIDs are, but NSAIDs are like non-steroidal anti-inflammatory drugs like Advil and Aleve, which you can buy over the counter. And those can definitely cause high blood pressure and kidney disease. And I don't know if any of you in the audience take Advil or Aleve, but if you do, open up the bottle and there should be a little piece of paper with it, a bunch of gobbledygook that you should just throw away. But if you look at it, it'll say that this medication might cause heart attack, stroke, and death. And so, seriously, if you guys are on these medications, you ought to consider not taking them if you have high blood pressure, or if your blood pressure is elevated while you're taking them, then that's not good. And these medications are over the counter. It's kind of interesting. 30 years ago, it was like you would give ibuprofen to everybody that had a sprain or a strain or any kind of painful condition. And now we're finding that these medications can even inhibit the healing process as well. So they're not the panacea great thing that we used to think they are. Other medications that can cause high blood pressure are some antidepressants, not all of them, but some. Prednisone, which is a steroid that we use to treat certain diseases like asthma or other allergic diseases, can also raise your blood pressure. There's some weight loss medications that raise your blood pressure. We now have some weight loss medications that don't raise your blood pressure as well. So there's some new weight loss medications that are out that don't raise your blood pressure. And then, of course, some illicit drugs like stimulants, like amphetamines and cocaine, raise your blood pressure. Usually those people don't go to the doctor, though. We usually try to stop that if we find that. Symptoms of high blood pressure. Anybody have any questions so far? As I mentioned earlier, oftentimes there's not a lot of symptoms. I have a new patient I started seeing probably 3 or 4 months ago, and he walks in and his blood pressure is like 220 over 120, and I go, "Are you feeling okay?" He goes, "Oh yeah, I'm fine." And how long have you been this? "Oh, a couple of years." You guys just walk around with really high blood pressure, which I don't recommend. But so he didn't have any symptoms, but we do see occasionally, patients say, "Well, I wake up with a headache, or sometimes I get a headache late in the day," and that's high blood pressure in some people. So if you're getting headaches, it's a good reason to check your blood pressure. Ringing in the ears is another symptom of high blood pressure, and as we age, we get ringing in the ears, but that can be a subtle symptom in some people. Fatigue. Fatigue is actually a common symptom of high blood pressure. I like to make the analogy of a pump, because basically your heart is a pump, pumping blood through your body, and your cardiovascular system are like pipes. Your blood vessels are little pipes, and so think about it. If you're pumping water and you have high pressure in those pipes, well, what's going to happen? That pump is going to get tired, or that pipe is going to burst, and that's exactly what we see in the cardiovascular system. So early on in high blood pressure, fatigue can be a symptom, and I find that sometimes once we get people's blood pressure under control, their fatigue goes away. Kind of interesting. Chest pressure can also be a symptom. Your heart's just working too hard. If a patient comes in with chest pressure, we also try to exclude a coronary artery disease, which is a blocked artery. And maybe I should mention there's hypertensive heart disease, which is heart disease just from high blood pressure, and there's coronary artery disease, which is related to just the arterial disease. But high blood pressure does lead to coronary artery disease as well. Another common symptom of high blood pressure is decreased exercise capacity. And same with that pump analogy. I have patients that are athletic, and a lot of people like to ride their bikes or go on hikes, and they're like, "Doc, I just can't get up that hill." And their blood pressure is 160 over 110. Like, well, just lower your blood pressure, and you'll feel much better. So, okay, we've been talking about some of the complications of high blood pressure. You mentioned coronary artery disease, congestive heart failure. That's when your heart pump is pretty much given out, and that's not good if you ever get that. Nowadays we have a lot of medications that can treat that as well, but the goal of treating high blood pressure is to avoid congestive heart failure. Stroke is a complication of high blood pressure. When I was in medical school in the early 80s, the intensive care units in Chicago were filled with people on ventilators that had massive strokes and brain hemorrhages from their blood pressure. And it was awful because at that point they end up either dying or be on life support, or have a horrible quality of life. The good news is now that we have good medications and awareness about high blood pressure, we don't see those horrible strokes like we used to, but they still occur. Chronic kidney disease, I mentioned, blood pressure, high blood pressure can cause that, as well as eye disease, and in men, it can cause erectile dysfunction, and a lot of men are worried about the blood pressure medication causing erectile dysfunction, but actually the high blood pressure itself diseases the arteries and can cause high blood pressure. Erectile dysfunction. There's certain medications that work better in men that have erectile dysfunction, so that's something to talk to your physician about if you do have that problem.
I have a great question.
Sure.
About nosebleed.
Nosebleed, people do associate that. If you have a nosebleed and you have high blood pressure, it's probably not from that. Most nosebleeds, 90% nosebleeds are venous, which means it's the vein, and usually it's causes common in Tahoe because of our dry air. An arterial bleed, that's usually a very severe nosebleed that the blood's actually squirting out. That can be from high blood pressure. Yeah.
Can I make a comment?
Yeah.
My blood pressure seemed to go up as I went through menopause, given my age, and it gave me headaches too. Both of those, and I didn't know what was causing what.
Well, menopause itself does not cause high blood pressure, but aging associated with that does, and the headaches might have been from the blood pressure. Yeah.
From my blood pressure,
Mm-hmm.
because it went up, and I wake up in the morning. I only get one in the morning if I get it when I get up.
A headache?
I don't ever get a headache.
Mm-hmm.
Is that due to blood pressure?
Well, if you are having that, I'd say check your blood pressure when you have a headache, and that way you know. There's other reasons people wake up with headaches in the morning.
It goes up as soon as I wake up for about 5 minutes, I'll take it. And as soon as I get up or walk around, the blood pressure goes back down again.
Well, that's good.
Yeah. Is that normal?
have a problem called labile hypertension, which is really hard to treat. And I think in the last few years, we've been less aggressive about treating labile hypertension because what happens when you hit those lows, then you can fall down and pass out and break your hip or something bad. So we're not as aggressive as we once were with labile hypertension. Okay, I guess we're going to move on to medications here. The first group of medications that I like to use are what's called ACE inhibitors. And ACE inhibitors, the most commonly used one is lisinopril. Lisinopril is a great medication. It's been generic a long time. It works great. It's super cheap. You can get 3-month supply at most pharmacies for $10 or $12 now. What ACE inhibitors do is they inhibit an enzyme in your blood called angiotensin converting enzyme. That's why they call it ACE. It's a lot easier to say. So with these medications, it reduces the level of angiotensin converting enzyme in your blood and then lowers your blood pressure. Another real nice thing about ACE inhibitors is if I have a patient with hypertensive heart disease or some heart issues, that medication actually helps your heart muscle. It's called remodeling, where your left ventricle, which is your main pump, actually, if it's enlarged and diseased, it actually can become normal with treatment after a few years on these drugs. So I really like the ACE inhibitors. They have very few side effects. The most common side effect of those medications is a dry cough. It's only about 1 out of 10 people get that. So it's a very good medication to start with. If you do get a dry cough from the ACE inhibitor, I generally move on to something called an ARB, and ARB stands for angiotensin receptor blocker. ARB is easier again. And these medications do something very similar to the ACE inhibitors. The ACE inhibitors do a little bit more than the ARB, so I usually start with an ACE inhibitor, and if you get a cough or side effect, then we move to an ARB. And then at this point, if your blood pressure is not controlled, then most physicians will add a diuretic. And every physician treats this differently. I'm just giving you my approach. And diuretics, what they do is they help your kidney release salt into your urine. And we talked about salt earlier as a contributor to high blood pressure. So the diuretics are very good in terms of removing salt from your system, and they work very synergistically with the ACE inhibitors and the ARBs. And if you combine those two medications, you get, I call it 1 + 1 = 3. You get a really good effect on the blood pressure that way. There are certain different types of diuretics. Oftentimes we use hydrochlorothiazide, which is a very good diuretic, and oftentimes a low dose of that will work very well. Occasionally people with severe high blood pressure and congestive heart failure will add things called loop diuretics or Lasix or Bumex, and that really makes you urinate a lot. A lot of people don't like those, but if we have to use them, usually you have pretty significant disease by the time we're using those medications. The next group I like to use are called calcium channel blockers. And again, the good news is almost all these medications are now generic, so the cost of treatment of high blood pressure has gone down significantly. What calcium channel blockers do, they block a channel in your blood vessel that lets calcium in and out. And by blocking the calcium channel, we relax the blood vessel, and we actually get the blood vessel actually dilates a little bit. So I like to use those if the other ones aren't working or you get side effects. And another thing I should mention as far as medications go, oftentimes we add medications. If you're not having a side effect, we'll continue the medication and add something else. It's not that we like to push pills, but what we find is if we combine different categories of these medications in lower doses, we have better control of your blood pressure and actually less side effects. 25 years ago, they used to advise physicians, well, push the dose to the maximum of each medication. And so what you happen is your patient gets a side effect, well, I'm gonna stop that, and then you go on the next medication, you push the maximum dose, you get a side effect, you stop, you know. So nowadays, I try to use smaller doses of several classes of these medications. You know, I think if you're having a side effect, that's really something to talk to your physician about, and we can tailor your treatment to avoid those kind of situations. The next class of medications we sometimes use are called beta blockers, and beta blockers, they block the beta receptors on your blood vessels and also on your heart. And most physicians, we don't use those too much as an initial treatment of high blood pressure. Most physicians nowadays, if you have heart disease or arrhythmias or palpitations or any electrical disturbance of your heart, we'll put you on a beta blocker because it calms down the palpitations and extra heartbeats. And beta blockers also help lower your risk of a heart attack. So if you've had a heart attack, it's a good medication to be on. Beta blockers can have more side effects. It lowers your heart rate, so it can cause fatigue. And so again, that's kind of a medication we don't use until we use the other ones, or if you have heart disease. The last medication I've listed up there is called an aldosterone antagonist, or spironolactone is a common one we use. And again, this isn't used in a lot of people, but I do use it in some patients that have low levels of potassium, because those patients probably have too much of a hormone on their body called aldosterone, and aldosterone, it raises your blood pressure. So those patients will have real hard to treat blood pressure and always have low potassium. So if I see that, I put them on the spironolactone, and usually that works like a charm, and that usually controls your blood pressure real well.
Quick question.
Yep.
How about some common side effects?
Of which one?
What are some of the common side effects?
Which medication?
Any of them?
Oh, okay. Well, there's a lot of potential side effects. You know, if you ever go to a pharmacy and look at that printout they give you, you know, maybe I'll hold it. Yeah. You know, there's too many to list. You know, I mentioned the cough and ACE inhibitor because that's in 1 out of 10 people. But what I tell my patients is, if you have a symptom, you start a new medication, you suddenly have a symptom that's persistent on a regular basis that you've never had before, and you're on a new medication, it's probably from the medication. You know, sometimes a patient come in and say, you know, 3 weeks ago my hip hurt. You know, I think it's that medication, doc. And I go, well, does your hip hurt now? No. You know, but you know, so you know, there's so many potential side effects. I wouldn't be able to get into all of that. But just keep in mind what I mentioned. Any symptom that's persistent after a new medication of any kind, it's more likely from that medication. And you know, usually it's a good thing to talk to your doctor before you start to just stop things on your own.
My son has an awful cough with the medication he's on.
He's probably on the ACE inhibitor. Yeah, so that's something he should talk to his doctor about. And what I do with my patients is then switch to the ARB, the second one down. And you know, as I mentioned a little earlier, you know, the cost of these medications is dropped dramatically. It's kind of interesting. You have to be careful. If you do have insurance, sometimes the insurance company makes you pay a higher copay because you have insurance. So what I do with some of my patients is just go to the pharmacy, tell them you don't have insurance, pay cash, and you'll get a 90-day supply for $10 or $12. So just something to keep in mind.
I just wanted to get your opinion on it. My mother has high blood pressure, very resistant to taking drugs because of all the side effects. How do you deal with a patient who doesn't want to take their medication because of that?
That's a very good question. Some people are really stubborn, but you know, what I say is just try it, and if you get a side effect, we'll stop it. And that's the reason why a lot of people don't have their blood pressure controlled, is they're just afraid of a side effect. But a real short answer would be, if you have high blood pressure, they do population studies of people that have had that have high blood pressure that are treated and people that aren't treated. And basically, you'll live longer and live healthier if you treat your blood pressure. So that's what I try to sell my patient on. But it is hard to sell people, like we talked about a little earlier, because you oftentimes don't have any side effect. And you're worried, oh, you're going to give me like a handful of pills and no side effects. But, at least in my practice, if my patient's having a side effect, I try to address that, and not say, well, too bad, because you're probably going to lose the patient anyway. So, yes?
Can side effects develop years after you've taken the medication? You've taken it for years with no problem, and then all of a sudden you get side effects?
That's a good question. Generally, that's unlikely, but it is possible. Usually you're going to get it right away, but it is possible. Yeah. Sometimes I'll see people with rashes, and you'll find that usually if you're on a new medication, you usually get a rash in the first month or two, but occasionally it can come on a couple years later. So. Yes?
Can vitamins disrupt any of these inhibitors?
When you say vitamins, like a multivitamin, probably not, but there's supplements that actually can interfere with medications, and some can raise your blood pressure as well. Not all supplements are really safe, and you got to be careful about taking supplements, because unfortunately the supplement industry is not regulated by the FDA, so you could buy a bottle of a supplement and it may not have any of that supplement in there. So you got to be wary of supplements. A lot of the bodybuilding supplements that some young men take can cause liver and kidney problems. I've seen that quite a bit. I'm not sure if I missed a slide, but I wanted to talk about, we were talking about complications. If we treat your blood pressure adequately, it can reduce your relative risk of a heart attack by 50%. When we talk about relative risk, it's kind of a hard number to digest. But the bottom line is treating blood pressure reduces your risk of heart attack by up to 50% in some populations. It can reduce your risk of congestive heart failure reduce the risk of heart attack by 50% and congestive heart failure by 50%. So heart attack by 25%, congestive heart failure by 50%. And also, adequately treating your blood pressure reduce your risk of stroke by 30 to 40%. And most Americans, 50% of Americans will die from heart disease. So this is a real big problem. We're all going to die someday. Hopefully, it's at an advanced age. We've had a great life, but treating your blood pressure adequately will more likely get you to that advanced age if that's what you desire. Any other questions? Yes?
What type of eye diseases are caused by high blood pressure?
Good question. We see something called hypertensive retinopathy, which is where your blood vessels actually can affect the retina, which is the main part of your eye you see from. Occasionally, I've had a few patients that have hemorrhages in their eye from blood pressure, and you could lose sight in an eye, and that's pretty rare, but it definitely can affect your retina.
Is there any symptoms for that, like pain in your eyes?
Like
pain in your eyes?
If you have eye pain, it could be related to blood pressure, but not necessarily retinopathy, because your retina doesn't have nerve endings in it. So you might notice you had a retina problem, you might start having blurred vision or distortion of your vision.
On exactly that topic, we have a friend who went in for an eye exam, absolutely healthy man. His
it's a real disease, and you know, I can't emphasize enough that it can be asymptomatic, or the symptoms are real subtle. It's not like, God, my knee really hurts, you know. So oftentimes people don't see a physician until it's too late. And you know, going to the eye doctor is actually a good screening for high blood pressure, because if you have hypertensive eye disease, that means you have pretty significant high blood pressure. Yeah. So yeah. Yes.
And it's borderline high blood pressure or low. I mean, you're 140, right now 140 and above, we've changed it. So if you run along 130 to 140 for a long period of time, depending on the individual, one might be able to handle it, another one might not.
Well, yeah, generally if you're below 140, you're probably going to be okay. It's kind of interesting. There's a group of experts that used to meet about every 5, 6, 7 years, and it was called the Joint National Council of Hypertension. And they started meeting. They met in about 2004 and published new guidelines of high blood pressure, which was targeting very low blood pressures, like getting everybody below 120 over 80, and we were finding that a lot of people were, you know, falling over, their blood pressure was getting too low. They were meeting for quite a few years, and because they couldn't agree on what's normal blood pressure, and so they didn't even publish their guidelines from the last couple of years because the experts in the panel couldn't agree. But what some wise experts did is they looked at some of the European data, and in Europe, they've been targeting blood pressure at 140 over 90 or below as a goal to treat high blood pressure. And the rates of heart attack and stroke, if you look at big population studies in Europe and America, are quite similar. So finally, you know, the American experts began to say, you know, we really don't need to target, you know, real low blood pressure. Probably below 140 over 90 is good.
Is dizziness on exertion, is that cause, if you're on medication, it means dropping too low?
Absolutely, yeah. So if you're getting lightheaded with you're on blood pressure medication and you're getting dizzy with an activity, it's probably too low. You know, again, you know, our population in Tahoe tends to be more active, and I tend to avoid diuretics unless I really need them in people up here, because the diuretics, remember, that removes salt out of your body, and that it kind of dehydrates you. So if I have a patient that's telling me, I'm getting, you know, dizzy or lightheaded with a prolonged activity, I usually will stop their diuretic if they're on that, or reduce their other medication if they're not on a diuretic. Yeah. And you know what? I'll ask my golfers, are you getting dizzy when you pick your ball up out of the cup, or you know, something like that? That's a symptom of low blood pressure as well. Yeah. Yeah. Yes.
Do diabetics need to have their blood pressure lower than the non-diabetic population?
Excellent question. That was a major bone of disagreement amongst these experts, and I think most experts now are recommending diabetics get down to 120 over 80, and we don't really accept 140 over 90 in a diabetic. So thank you for asking that question. That's a very important question, because diabetes is a major cause of heart attack and kidney disease and eye disease, and the incidence of diabetes in our country is increasing dramatically due to the obesity epidemic in our younger population. So diabetics we definitely target lower. And in the diabetics, we like to use the ACE inhibitors and the ARBs more, because they have a protective effect on the kidney.
Could you put some medication names next to a few of those items there?
Sure. For the ACE inhibitors, lisinopril is probably 90+% of the prescriptions. Lisinopril. Lisinopril, yeah, it's like it sounds, yeah. And then the next category, the ARBs. Losartan is a real commonly used one, and losartan's claim to fame, it was the first ARB to make it to the market. The problem with losartan, it's the weakest of the ARBs. So since it was the first to make it to the market, it's the first to go generic, and it's the first the insurance companies kind of mandated that you take. The good news is a lot of the other ARBs have gone generic that are more potent. I tend to not like losartan because it's not as effective and it wears off, so I don't like it. There's valsartan in that category is a very good one, and also something called telmisartan just went generic, and that used to be called Mycardis. Anything that ends in a sartan is an ARB. Diuretics are typically like hydrochlorothiazide. There's also one called triamterene hydrochlorothiazide we use a lot, and then the loop diuretics I mentioned are like Lasix and Bumex or furosemide is the other name for Lasix. And then calcium channel blockers. Most common one physicians use is called amlodipine. And that's a calcium channel blocker that does not affect your heart conduction. If patients have arrhythmias, we'll use other ones like verapamil, which can help with other problems of the heart in terms of arrhythmia. And then beta blockers. That's an interesting one. Atenolol was again the first beta blocker to come to the marketplace back in the mid to late 80s, and it was a once-a-day medication, and it was touted as this great medication. And it's kind of interesting. We found from follow-up studies over the years that it's not a very good high blood pressure medication, and it doesn't reduce your risk of stroke. So most physicians don't use atenolol anymore. We tend to use something called metoprolol or carvedilol are the two that I use the most. There's also something called labetalol, and again, all these medications usually end in a, like beta blockers are OL, yeah. And then the aldosterone antagonist, spironolactone is the most commonly used one. There are others, but they're not generic, so I don't think too many physicians use them. Any other questions on medication? Yeah.
I monitor my blood pressure periodically, and I find when I do the blood pressure testing, I can get a variation of about 20 points within 5 to 10 minutes. It can be starting off at 140 over 80 and drop down to 135 over, which is the real blood pressure.
Does it tend to drop when you check it? Like
up and down.
Up and down, okay.
They're on the 135, no, 147.
Okay. Okay.
5 minutes or 10 minutes.
Yeah, that's another very good question. Thanks for asking that. What we tend to do when you come to the doctor's office, the assistant will bring in the room, and then they'll ask you a few questions and check your blood pressure, and which is just normal protocol, I think, just about everywhere. And occasionally that first reading will be high. So what we should really do is have you sit in the room for 10 minutes and then come talk and check your blood pressure. But generally that's not real practical. But typically, if the initial blood pressure is high, when my assistant takes it, I'll usually recheck it. I didn't really answer your question, but one thing is the home monitor. Is that what you're using, a home blood pressure monitor? Okay. You got to make sure you're using it right. And what you should do is there's a hose that comes out of the cup, right? Okay. You want to have that hose, and I'm going to just point to my arm for a second. You kind of want it on the inside of your upper arm, like the hose in line with your pinky and your ring finger. Okay. So that. Okay, so your brachial artery, which is what we check, it's right there. Can you see my fingers? Okay. So if I have my hand out like this, it kind of lines up with my index, my ring finger and my pinky. So make sure the hose is on the inside of your arm with your palm facing up. So that could be why. If you don't have it in proper position.
Just bring the hose through your hand up to your cuff.
Well, you have the cuff on your upper arm, and then have your palm facing up, and the hose aligned with your ring finger or your pinky, with your palm up. Yeah. And then the other thing you want to do is try to have the cuff about the level of your heart. Okay. So your heart, it tends to be about 5 inches from your collarbone in most people. So you want the blood pressure cuff about that level. If you have the blood pressure cuff too low or too high, it can give you also, readings that are up and down. Yeah.
I try to keep it the same level, but still get this ups and downs.
Well, check where your hose is, and then again, you might have labile hypertension too. I try to discourage people from taking it too many times in a day because, in blood pressure, when I used to work in hospitals, we would sometimes put in an intra-arterial blood pressure monitor, so we'd have a catheter right in an artery, which would give you true real-time blood pressure without a cuff or anything, and it was, it's pretty much foolproof. It's kind of invasive. Usually you're really sick. God forbid you need an intra-arterial monitor, but what you do see is a lot of fluctuations. It's almost like waves in an ocean where you'll go, up and down. So I try to discourage people from checking it too much, and then I think then you get nervous. And you're like, oh my God, it's high, and then it goes even higher because you're nervous about it. Another thing I'd like to interject is the best time of the day to check your blood pressure is when you first get up in the morning. Most heart attacks and strokes occur between 4 a.m. and 8 a.m. And the reason for that is your adrenal glands start to wake up around 3, 4 in the morning. And your adrenal glands secrete cortisol and adrenaline, and both of those natural occurring hormones raise your blood pressure. So the experts feel that most heart attacks and strokes occur in those early morning hours because of the bump in natural occurring hormones. So what I have my patients do is check their blood pressure first thing in the morning before they get up and start moving and before they have any coffee. And that's the most important blood pressure first thing in the morning. And coffee will affect your blood pressure in about 45 to 60 minutes. So if you've had coffee, don't check your blood pressure for like an hour. And if you know you have a doctor's appointment, maybe early in the morning, maybe don't drink the coffee or drink it early before the appointment. So, by late morning, if you only drink coffee in the morning, late morning, early afternoon, the caffeine is out of your system. Like I said, usually about an hour, the effective caffeine is gone.
So also, if you're sitting or laying or standing, it's going to change the blood pressure too.
Absolutely, yeah.
In case he takes it sitting one time and standing the next, it could skew the whole thing.
Yeah, are you sitting down when you check your?
Yes.
Yeah, that's a good question.
I can actually relax and just sort of drop it 20 points within 5 minutes.
How do you relax?
Just sort of sit there and just kind of do a very relaxing state.
Do you take deep breaths?
Deep breaths. I take deep breaths.
Yep. We'll get to that in a few minutes about how deep breathing and relaxation lowers your blood pressure. It really does, yeah.
I read in art that you should have both arms because each arm will have a different. So when we're in the doctor's office, we only have one arm.
Right.
What is your recommendation?
If your blood pressure is okay in the arm we check, I usually don't ask for trouble. Well, we do shop around. If it's high in one arm, we check the other arm. And you can't have a 10 to 20 point variation in your arms, and there's a number of reasons for that. So what I'll tend to do is average the two numbers together of both arms. But if it's real big difference, then that's something we need to look at because sometimes you'll have a narrowed artery or maybe a problem with your aorta or something like that. So if it's a really big difference, but it's pretty normal to have a different blood pressure in each arm. And again, hopefully it's not more than 10 points. We can go up to, if it's more than 20 points, then you may have a problem with 20-point difference in each arm. Yeah.
I hate when they change the medication to generic, and all of a sudden you're getting something else. Like the Synapro, is that,
Well, there's Quinipro, yes. It's in the same class, yeah. Yeah, it's an ACE inhibitor. It was popular for a while, but I think most of the cardiologists and other doctors I work with, we all generally use Synapro. It's just cheap and it works, and I think it's a little bit more potent than Quinipro.
I have an odd question. What if you have really low blood
It can be. Used to be a low blood pressure get dizzy really easy, especially when they stand up, and they can be fatigued a lot. Typically, and you can get a headache even if you have low blood pressure. But that it's not that common, but it does happen, and those are the patients who will actually tell you need to start eating salt. And yeah. But occasionally that's a sign of other diseases, so if you do have like lightheadedness when you stand up, it could be anemia or other things, or it could be an arrhythmia with your heart. So that's something, you have dizziness when you're standing up, or oftentimes have dizziness, that's something you should see a doctor about.
How good or bad is the cuff?
The wrist cuff?
Yeah.
The wrist cuffs, I don't like them as much because your radial artery, it's the artery in your wrist, it's encased in a lot of bone. And so, depending on your individual anatomy, if you have a lot of bone that's covering the artery in your wrist, you don't get an accurate reading. I know, I think every time I've been to the dentist, they've used the wrist cuff. But I tend to not like those as much. If you do have one, we just try to work with it. But if I had a preference, I'd have everybody buy an arm cuff.
You told me once in the hospital, they use those on people who have breast cancer, who are born, they have noses in their arms, so you can't because they swell. So they can only use the wrist.
That is true. That's another good question. That is so overblown. If women have had a mastectomy and a lymph node dissection and they don't have swelling in their arm, checking the blood pressure is not going to cause a problem. I think a lot of the surgeons are getting away from telling people that. It's pretty rare now that we see people that have that chronic swelling in the arm after a mastectomy. It does happen, but it's not that common, and that thing is way overblown. I tell patients, don't worry about it. Your arm's not swollen, and having a cuff on you for 20 or 30 or 60 seconds is not going to cause you a problem. Yeah. So that shouldn't dissuade you from checking your blood pressure. Okay. Okay, this is one of my favorite topics, lifestyle modification. The interesting thing is, with lifestyle modification, it can reduce your blood pressure as much as 2 medications. And some patients, I mentioned, I have some really fit, very healthy patients that, there's nothing you can do about their lifestyle, and so you have to give medication. But a lot of people, you can control your blood pressure without medication. And smoking, obviously or not, that's a major risk factor for high blood pressure and stroke. And, if you stop smoking, if people smoke and you get them to stop, their blood pressure will drop oftentimes 20 or 30 points within a year. It doesn't happen right away, sometimes even take 2 years. So what I tell my patients is, okay, you have high blood pressure, you just quit smoking, it's going to take a while for your blood pressure to go down, and as your blood pressure goes down, we'll reduce your medication. What I don't want to do is, okay, you stop smoking, we'll stop your medication, and then your blood pressure goes up. So that's another thing where you want to be in close contact with your provider to monitor your blood pressure if you do quit smoking. Excessive alcohol intake is another major problem for high blood pressure. It's really hard to treat a patient that drinks too much because when they're drinking, their blood pressure is really low, and when they're not drinking, it's really high. So it's really hard to control blood pressure in people that drink too much. But again, we do know that if you drink too much and stop drinking, it'll lower your blood pressure significantly.
Can I ask a question on that?
Yeah.
So, if, will it affect your blood pressure if you save up your 1 drink a day and have it in 2 days and have it?
It might actually be worse. I mean, it depends. Like, if it's, it sounds like you're talking about a light drinker. If you don't drink and then you have 3 drinks 1 day a week, that's not that bad. I'm talking about, the people that I was questioning a patient recently. I said, well, did you stop drinking? And He said, well, I quit drinking hard liquor. I'm just drinking a little bit of wine now. I said, oh, okay, good for you. What's a little bit of wine? 3 or 4 glasses a day. So, which is about a bottle, so I mean, it's all relative. But again, a patient like that, it's really hard to really control their blood pressure. And again, the smoking and drinking thing, it's really hard to get people to quit that. But I really try to, discuss that with them on repeated office visits. Exercise. We know that exercise reduces your blood pressure. And again, I mentioned a little bit earlier, you don't have to do extreme exercise. You can just walk for 30 minutes a day, and depending on your age and your level of conditioning, just simple walking. 30 minutes, 5 days a week will lower your blood pressure. And actually, they did a study on people that had congestive heart failure, and they found that the people, this was pretty sick patients, the patients that walked actually lived an average of 2 to 5 years longer than the people that didn't do anything. So this is dealing with advanced heart disease. Walking is still good for you. Congestive heart failure is, there's several causes of it. Since we're talking about high blood pressure, again, I talked about that pump analogy, and basically your pump just gets tired, and it can't pump anymore. And so, there can be a thickening of the left ventricle, and again, we try to catch people before they get to that point, but as mentioned, some of these medications can reduce that thickening of the heart muscle. And then once the heart muscle thickens, then the heart can begin to dilate, and then the valves get leaky, and then it's kind of like hopefully, I hate seeing patients at that stage, but, Right, and it ends up in your lungs, and so, I don't know where the classic description is, but you get congestion in your lungs, and you get hard time to breathe at night, and coughing, and that's bad.